Okay, we are live. We can begin, Dr. Amol.
Okay, thank you. Very good evening, one and all. Uh, Myself, Dr. Amol Patil, Senior Medical Advisor from Ferring Pharmaceuticals Private Limited, India. Welcome you on behalf of Ferring for this very interactive webinar today, which is going to be focused on practical considerations and IVF lab practices in COVID-19 era. And this is going to be a highly practical webinar, which is going to give us really key learning points based on the panel discussion that we are really looking forward to. So that's the webinar we welcome you to, IVF laboratory practices in COVID-19 era. Ferring, as you all know, is a research-driven specialty company, and it's focused always on its innovative treatments in reproductive medicine and maternal health. And we continue on our journey to be a scientific partner in these challenging times of health crisis. COVID-19 has locked down many services, and infertility was also being locked down for quite a few months. But this is just one statement taken from one of the Italian Society of Reproductive Medicine guidelines. We consider it ethically correct to allow infertile couples to maintain a viable chance of future pregnancy through this pandemic, and that's what everyone is looking forward for. Of course, embryologists are one of the most important integral component of this entire journey of infertility management and IVF. And at this moment, I just want to highlight this particular point from a very good paper which was published 5 years ago, that although the technical skills of embryologists are critical, their contribution to quality is equally conveyed through a knowledge of reproductive biology, keen observation, judgment, astute decision making, wit to work under pressure and time constraints, sense of mission in provision, and continual development of a safe and effective laboratory. And I think this a safe and effective lab is something coming so much in picture now, where all the embryologists are really going to be champions. So that's going to be the highlight of the day. And I think our moderators will take us through that very soon. We'll start with a talk followed by panel discussion. And it gives me a great pleasure to introduce our two moderators for this entire event and who have been like the uh, integral component, who have been like the people who designed this concept and being leading this webinar right from the front. So first of all, I introduce Dr. Ved Prakash. Most of us definitely know him. He's a lab director at Southern Fertility and IVF, Delhi NCR. He's trained in IVF and ICSI from Embryology IVF Lab, KK Women's Hospital, Singapore. And he has advanced IVF ICSI embryo biopsy training at Brussels. And he's the Vice President, Academy of Clinical Embryologists, India. Welcome on board, Dr. Ved Prakash. And another great pleasure to also introduce Dr. Gaurav Majumdar. His master's degree in clinical embryology from National University of Singapore in 2001, currently chief embryologist, Center for Reproductive Medicine, Sir Gangaram Hospital, Delhi. He has successfully set up PGS-PGD program, which now runs an in-house genetic testing facility using quantitative PCR to screen embryos for aneuploidy. He was awarded the Economic Times Fertility Award for Best Embryologist of the Year, India 2019. Numerous publications in international journals, contributed 4 book chapters in ART textbooks, and he's the joint treasurer of ACE India and executive member of IFS India. Welcome, Dr. Gaurav, as well on board. And of this moment, I hand it over to you, dear moderators, and enjoy the flavor. Thank you.
Thank you, Dr. Amol, for nice introduction. Good evening, everyone. As you all know that we are going through an unprecedented scenario of COVID-19. In this situation, it became a challenge for all infertility centers to resume clinical and laboratory practice with all safety measures. Today, we are here with some practical questions which need to be addressed. For that, we have expert panel that will throw light on how to restart our lab practices. There are recommendation from Indian societies like ISAR, IFS, and ACE, and international society like ASRM, ASHRAE regarding restart the IVF practice, and they are updating it regularly. To understand these guidelines, we have Dr. Pranay Ghosh. We will speak on a safe laboratory practice in COVID-19 era. Dr. Pranay Ghosh is Director Elixir Fertility Center, Delhi. He is consultant double helix clinical cytogenic and reproductive immunology center. He has done medical science in ART, University of Nottingham, UK. He has done diploma reproductive medicine from Kiel University. He is specialized in reproductive medicine, NUS Singapore. He is SRA certified clinical embryologist. And over to Dr. Pranay Ghosh.
Thank you, sir. Thank you for the kind introduction. And at the outset, I'd like to thank the moderators, Dr. Ved Prakash, Dr. Gaurav Majumdar, and Dr. Amol Patil from Pering for having me here. And today I'll be briefly talking about and giving you an overview of the guidelines that we have for resumption of safe laboratory practices as we struggle to work during the pandemic. So we know that the COVID pandemic is an unexpected health emergency that we have had to face, and this has confronted us with a radical change in our management of our work routine and our life in general. And as we speak, in India, we haven't yet reached the peak of this contagion curve, and we don't even know where we are on the curve. And we really don't know what curve we are talking about, whether it's a single spike followed by abatement of the pandemic, or are we yet to see multiple spikes of the same? So in the field of reproductive medicine, this has led to recommendations from the major scientific societies to first suspend their IVF treatments. And once plateau has been reached in their specific countries, a resumption of these fertility services has been recommended. So even though this emergency demands the postponement of the new treatments, we have to be very mindful of specific patient subgroups like those having oncofertility needs and poor responders, and even patients having severe oligozoospermia or azoospermia. So with that, let's just have a look at the timeline of this COVID, right from the months of February to May. And ESHRE was very specific with regards to the statements that it was directing towards the patients who were getting pregnant. Initially, it said that the COVID positive patients should avoid becoming pregnant. And then in March, it said that all fertility patients should avoid becoming pregnant at the time of the peak of the pandemic. In the months of March, ESHRE advised that all ARD centers should suspend their activities, with the exception of offering urgent fertility preservation to the oncology patients seeking oncofertility services. As the peak of pandemic passed and the cases plateaued in these countries, the ESHRE recommended a recommencement of the ARD services in a phased manner, and we'll look into some of the recommendations in the coming few slides. So with regards to the concerns of the virus being inside the lab, I think I can safely say that the lab is one of the least likeliest location which can get infected in the terms that it is an isolated location. It is endowed with a good air filtration unit. You have ample number of air changes per hour. Then you're working with a controlled patient population who are not diseased per se and are infertile patients. And above, we are working with pre-screened low-risk specimens, but even then we have some exposure concerns regarding the staff to staff, patient to staff, staff to patient, and patient to patient contamination occurring. Then the contamination can be passed on from the staff to the samples, and there can be a cross-contamination between samples. Then there is a lot of mixed information coming to us with regards to the transmission of the virus to the gametes, whether it be the semen from the patients who have contracted the COVID infection and have recovered. So there have been ample publications, most of which mention that the virus cannot be detected in the semen from patients who have had prior COVID infection. But we have to be mindful that there are lots of gaps in the information, and everything is in a state of flux, and all the information coming to us is new and will be updated. So there are some papers that are saying that active and recovered patients do show the COVID infection in the semen. Fortunately, the COVID has not found to be detectable in the vaginal fluid of women with a severe COVID infection and even those with active pneumonia. There are other publications as well that are showing the absence of COVID in the semen and testes of patients who are active COVID or who have recovered, or even from the ones who couldn't make it in the specimens from the diseased patients. It was found that the COVID was not transmittable from the bloodstream to the semen and the testes. but we have to take it with a pinch of salt because all these publications have a lesser academic rigor because they have not been subjected to peer review process, and in the haste of publishing it, they have been published in a lot of low impact factor journals, and even the ones that have made it to the high impact journals have been retracted on a couple of occasions. With that being said, we now know that the virus is here to stay, and we cannot endlessly keep on delaying the fertility needs of our patients, whether it be the oncofertility patients or patients who are awaiting their frozen embryo transfers. Patients are not willing to wait. Unfortunately, the Fertility Societies of India, the ACE, ISAR, and IFS have come up with a joint recommendation on how to go about resuming your ART services. And the aim of these is a measured resumption of care. The tenets of these recommendations are providing adequate information and specific consents to the patient, patient selection and prioritization, triaging, and then resuming your treatment once the patient is found to be pre-screened and okay and has been given a go-ahead. So when we talk about the information and consents, we know that there are a lot of gaps in information, and the information is ever emerging. Unfortunately, we have a lot of patient resource centers and guide websites which have a lot of information coming in and being updated on a daily basis. And not only does it provide information to the patients, it is also open for physicians. A couple of these are the SHA and the ASRM websites, which update their recommendations on a bi-weekly basis, which has now been phased out to a 4-weekly basis, at least for the ASRM. And these have a patient resource center where they go on to answer the commonly asked questions from patients and would allay their concerns. Then we have to be mindful that we have to modify our consents, and they would not be the same as in the pre-COVID era. And we have to take a declaration from the patients coming in that they know well in advance the risk associated with them coming to the fertility center with regards to them getting infected from the personnel, or whether passing on the infection from themselves to the personnel. And that we don't have a lot of information with regards to the disease outcome and with regards to the fertility outcome of the patients if they embark on the fertility journey. So the information regarding how these pregnancies would behave in the first trimester, in the late second trimester, whether they would have any high incidence of premature delivery and so on and so forth is lacking. So the information is ever emerging. We are making it available to the patients, but we have to make sure that they understand that this goes into their consents, and they would not hold the fertility unit responsible for any mishaps later on. With that being said, patient selection and prioritization is also very important. We have to be aware that there are some patients that we cannot refuse and have not been refusing even during the lockdown. And this particular categories of the patients who are suffering from malignancy, and they have been offered sperm, oocyte, or embryo freezing even during this lockdown. So these are a subgroup of patients who cannot wait. Then apart from that, patients who are having diminished ovarian reserve or advanced maternal age, these are patients who lose out on their chances of pregnancy with each passing month if they decide to have cycles. So in the wake of current scenario, where we don't have the information as to how long we would be actually waiting for a vaccine, it makes sense to embark on the fertility treatment for at least these subgroup of patients. And so as with male partners having severe oligozoospermia or non-obstructive azoospermia, where the chances of the prognosis of the patient worsen with each passing month. With that being said, there are a subgroup of patients who can actually wait, and these are the ones that are awaiting the third-party reproduction options, wherein the clock is not ticking for them. So the patients who are being offered oocyte donation, and especially surrogacy in couples who are not in resident in the treating city, where the surrogate is in a different city and the intended parents are from a different city, where they would fly into the city and would not be able to do so because of the lockdown restrictions. These are non-emergent conditions and can wait and can be deprioritized as of now. With that in mind, the next tenet of the recommendations lies on triaging both your staff and the patients. And the key principle is that we would be offering services to our patients once they are and once and only if they're triage negative or are asymptomatic. And the same goes for our staff. They have to fulfill a triage questionnaire on a daily basis, and only if they're some asymptomatic and triage negative, they're allowed to work. Otherwise, they are advised testing or quarantine if they come out to be positive. So this is just a summary figure treatment cycle taken from the ESHRE, wherein it has been outlined that we are offering the services to only triage negative patients, and once they start their stimulations, it is a good time to be offering them the COVID testing. I do not necessarily agree with the Igg Igm testing. You can have so there is a lot of debate between what specific COVID test to be offered with regards to their false negatives and so on. But they have to be offered if the regulations in the state and the country allow testing of the asymptomatic patients. They have to be tested on day 2 and ideally on the day of trigger if they are undergoing a fresh stimulation, so that we can decide if either of the partners comes out to be positive. We can actually go ahead with the procedure of the oocyte retrieval and decide to freeze oocytes if the male partner is coming out to be positive, and if the female partner comes out to be positive, we have to abandon the treatment. So makes and even the latest update of the ASRM recommendation mentions that you have to be offering the asymptomatic patients COVID testing to embark on the fertility treatment. So treatment, when we are resuming a treatment, we have to make sure that we have ample staff for the designated treatment cycles. And if you have ample staff, you can divide your staff into mini teams so that you can minimize the exposure, so that one of the shifts is working totally separate from the other at a different time period, maybe a morning and an evening shift. And this can ensure physical distancing, which is one of the most effective ways of negating the effects of COVID, both in time and space. The good laboratory practice is to be kept in mind as it was being followed in the pre-COVID era, wherein you handle all the samples as if they were infected, even if you have, or especially if you don't have a COVID report for them. And specific PPE can be advised for various procedures. And now we have a lot of information from the ASRM with regards to each particular diagnostic procedure and what particular PPE is to be used for that, and we'll touch upon it in a minute. So you have to be wearing a proper medical mask, gloves, working in a class 2 cabinet, and these are times where you have to reinforce your GLP in the lab, especially if you have not been following it pre-COVID in the Indian scenario in the pre-COVID era. A lot of emphasis has to be paid to the workflow with regards to the scheduling of the patients. And since we are restricting our talk to the laboratory concerns with regards to resumption of fertility treatment, or not to talk about that, but we should be encouraging our patients to produce a sample off-site so that it can be transported to the lab within a span of 30 to 60 minutes without causing deterioration of the sample. And if the lab policy was to allow the patients for the procedures in the OT or the embryo transfer suite at the time of the procedures, this has to be discouraged now and has to be avoided. You have to have a specific disinfectant to disinfect all the consumables and media, and this disinfectant has to be non-embryo toxic, and we'll talk about it in the later slides as well. An important point is that the staff may require retraining and training, especially for the junior and the trainee embryologists. And you're looking at a revision of your standard operating procedures, especially if you're looking to include something new, like introduction of a closed system of vitrification, wherein you were previously working with open systems. You have to train all the embryology staff and acknowledge that they do understand that the SOPs are being revised, and this has to be documented. Then if you had stopped all your operation during the lockdown and switched off your equipment, then this equipment, when it is switched on, does require a recalibration and a revalidation before it can be put to use. So this is one of the tables taken from the second update, the third update of the ASRM recommendations, wherein they have mentioned the risk associated with each procedure inside the ART unit and the risk mitigation strategies for the same with regards to the appropriate PPE to be used. And this has been revised in the latter updates. So in the update 5, we know that if we are carrying out the oocyte retrieval or intrauterine insemination or embryo transfer without the need for an anesthesia and only using local sedation, we can very well use a medical grade mask and gloves, and there's no need for donning the entire PPE, especially by the embryologist. So this is a great resource that you can refer back to, and it's freely available on the ASRM website under the patient resource and the physician resource center. So when we talk about changes in our cryo storage, we don't know whether cross-contamination can occur between the infected tissue samples and the non-infected samples, but we don't have any reason to believe that these viral particles would be any different from the other viral particles that we were mindful about in the pre-COVID era. But still, until proven otherwise, these samples have to be handled in the same manner as you would for a seropositive patient for any other disease. Then there should be consideration that should be paid for shifting over to closed system of vitrification like HSV straw, especially if you're not designating a specific separate cryo tank for these patients. There has been a lot of talk in a lot of webinars regarding vapor phase storage, but I personally feel that the risk of thermal damage in the vapor phase is a lot more than the risk of actually cross-contamination if you're using liquid nitrogen. So I would stick to liquid nitrogen storage for now. And you can consider having a separate cryo container, but if you're doing so, you have to factor in the additional cost, space, and time required to monitor the cryo tank, along with additional alarm systems, which have to be a must now. So this is just a run through, which I've taken from the document issued by the ASSR and IFS regarding the joint recommendations. And we have touched upon a lot of these. We have talked about deep cleaning if you have shut down our procedures and have the lab non-running for a couple of months. And even though we consider the lab one of the safe locations, we have to be mindful of the risk of infection and cross-contamination between the samples. You have to adhere to the good laboratory practices. You have to have the proper PPE for each designated procedure as outlined by the ASRM in their updates. Then one of the important points is to train your personnel apart from the ones inside the embryology lab. So you should be looking to train your clinicians and nurses into how to refill the cryo tanks in order to safeguard the cryopreserved material. It's a good time to be having electronic witnessing, but I'm pretty sure that we cannot all afford the same. And in the absence of the same, we have to trim our protocols. We have to outline lean protocols so as to minimize the need for physical witnessing. I think a lot of units have counseling of the patients, especially on the day of retrieval and the day of embryo transfer by the embryologist. But now is not the time to do so. And if you're in a situation where this is unavoidable, it is recommended that you use telecommunication devices for the same. Then when you're using or working on follicular fluid and sperm, you have to be mindful that now you have to be donning appropriate PPE, whether it is gloves and mask, and especially when you're disposing the samples, you have to dilute the samples. Then in a lot of webinars, I've heard about UVC light being used because it is virucidal and it can be used for disinfection, but you have to be mindful that at least a couple of regulatory authorities and the NIH do not recommend the use of UVC in the embryology lab, and I wouldn't do the same. So you have to make sure that if you're using UVC for virucidal purposes, you have to allow sufficient air changes to flush away the ozone generated by the radiation. We've talked about how to handle the semen. You have to receive the semen specimen container in a tray, and once you receive it, you have to wipe it off with a suitable disinfectant. You have to be using sterile type 2 hoods, and re-emphasize this because a lot of units in India are not using type 2 hoods for either handling the sperm or the gametes or the embryos. So this is a particularly distressing time for us not to be working and adhering to good laboratory practice, and we have to relearn the GLP if we haven't been adhering to it in the pre-COVID era. We have emphasized that off-site semen collection has to be encouraged, and we have to make sure that if we are doing so, we are informing the patient regarding the risk of sample deterioration, especially if they're not able to produce get the sample to the lab within 60 minutes. And then a point has to be made regarding the use of sperm counting chambers to have them properly cleaned between 2 uses and allow appropriate time with regards to the disinfecting agent between the users. So this is a good time to be investing in disposable counting slides, which can be an alternative. A lot of talk has been generated on previous webinars regarding what particular agents for disinfection to be used. So as of now, if you look into the CDC EPA website, there are a plethora of agents. Over 420 products are listed on the website. And whenever you're considering a disinfecting agent for your lab, it is especially important that you use one that generates minimal or no VOC at all. And a good idea is to perform a bioassay for the same. So the commonly used laboratory cleaning agents are hydrogen peroxide in a percentage of 3 to 6%, quaternary ammonium compounds, ethanol, which is to be discouraged because of the higher VOC generation. What you have to be mindful of is also the contact period for each particular virus. And here in case we are talking about the COVID, the contact period for different virucidal disinfecting agents may vary. So for example, if you talk about the quaternary ammonium compounds, the CDC gives a contact period of at least 10 minutes before you are good to go for the between the cases. So to summarize, I would say that we cannot keep on waiting endlessly to resume our fertility practices, and we can go on and have a phased resumption of services whenever it is deemed safe in the community. And the latest update of the ASRM with regards to the recommendations regarding restarting states that if the prevalence of the COVID in the background population is 2% or less, you can actually restart the facilities. The most effective way of negating the effects of COVID is to have a physical distancing, both in terms of time and space. We have discussed having appropriate PPE. You need not be donning the entire PPE set for carrying out procedures like IUI or scanning or even embryo transfers if you are not doing it under anything that causes aerosol generations. So if you're not intubating your patients using sedation, just a medical grade mask and gloves would suffice. Emphasis should be placed on triaging, because you would be able to have a lot of patients who would otherwise not be screened prior to them landing up on at your facility on day 2 and day 3. And this is a good time for us to be leveraging the technology of telehealth and telemedicine to triage our patients right at the source before they land up at your facility. Ensure adequate staffing with regards to the procedures that have been planned. Revise all your SOPs and policies that now have to be specific to the COVID, so the declarations and the concern modifications that we discussed. And we know that there are a lot of gaps in the information, but we should be providing our patients with the appropriate patient resources, and we should be redirecting them for any of their questions and answers. So we now know that there are a lot of these, and these would fulfill and allay any of our patients' apprehensions. So this is a summary of what the guidelines, whether European, American, or Indian guidelines have to say. And with that, I would like to end my presentation. Thank you.
Thank you, Pranay, for a very, very crisp presentation, because there are so many guidelines out there. So it's important to hear the crux of all of them for people. And now the whole point of this panel discussion is, because we heard things like where you mentioned that it's ideal to have teams in the IVF laboratory. But we also know that for majority of labs, it is possibly not practical to have teams because there's a shortage of staff. So these are the kind of questions that we are going to discuss with this distinguished panel of ours. And we will now introduce all of our expert panelists and then begin the discussion. So Ved, I'm going to share my slide here. Okay. So to begin with, I'd like to invite Dr. George Liperis as our expert panelist who will take part in this panel discussion. He's the Deputy Scientific Director at the Westmead Fertility Centre, University of Sydney, Australia. And he's a ESHRI certified clinical and research embryologist, practicing clinical embryology, combining genetic analysis and research in human reproduction. His current position is that of Deputy Scientific Director and Laboratory Supervisor at Westmead Fertility Centre, University of Sydney. His research interest consists of development of improved methods of assisted conception. And during his studies and professional career, he has developed a range of clinical research and teaching skills. Over the years, he has been invited to teach at workshops and present at a number of international conferences. And his list of publications include book chapters in routine quality control of variable in the IVF laboratory. Welcome, George, to this panel.
Thank you, Dr. Gaurav, for the kind introduction. Thank you, Ferring. Thank you, Dr. Amol Patel, and thank you, Ved, for coordinating this event.
Next, I'd like to invite Dr. Sanjay Shukla. He's the lab director at Baheti Hospital, Jaipur, and Shivani IVF and Fertility Center, Jaipur. He's a PhD in life sciences who started working in the field of human reproduction since 1998. And then he went on to get a fellowship in 2006 in biology of reproduction from Argentina. Currently, he's the secretary of the Academy of Clinical Embryologists of India, and he's also the chairman of the academic wing of the Academy of Clinical Embryologists India, and he's also taking care of the newsletter of this academy as the editor. Welcome, Dr. Sanjay Shukla. Next, I'd like to invite Dr. Sarapreet Singh. He's a senior consultant and chief embryologist at the Artemis Health Institute. He's the coveted ESHRI certified senior clinical embryologist amongst us. And he was the convener of the Indian Fertility Society Special Interest Group for Clinical Embryology for the past 2 years. And he won the Champion of ISAR Award at the ISAR conference this year. And now he's convening the Special Interest Group for Applied Genetics for the next 2 years. His area of interest is cryobiology and male infertility. Welcome, Dr. Sarapreet.
Thanks, Gaurav, for the kind words.
And finally, I'd like to invite Dr. Krishna. His current position is that of Scientific Director at the Oasis Center for Reproductive Medicine, Hyderabad. And he is a master's in clinical embryology from Monash University, where he passed out in 2008. And then he's gone on to do a postgraduate diploma in reproductive science from Monash. At Oasis, his main areas of work are cryobiology again, and he's also interested in IVM, in vitro maturation, andrology, and men's health. Currently, he's working on employing newer techniques to improve the success rates of IVF in PCOD and recurrent IVF failures. Warm welcome again to you, Krishna.
Thank you, Gaurav.
All right, so that's our distinguished faculty who is going to participate in this very, very important panel discussion today. And so wait, let's begin the panel here. So we are going to talk about the changing trends as far as embryology practices in the COVID era are now concerned. Many of us have probably just begun our laboratories after the lockdown has ended in our countries. George is in Australia, and most of us are representing different parts of India. Whereas in George's country right now in Australia, the pandemic is on its downswing. In India, it is very much on its upswing. So we'll get to hear two very important aspects of how to deal with an increasing pandemic and a subsiding pandemic. So the first question that I'd like to ask Dr. George Leiperis here is that what are the major changes in the laboratory or the protocols in context of starting afresh in this era of COVID, if people haven't begun? So what are the most important things that would come to your mind before you start IVF?
Thank you, Gaurav. And indeed, we have been lucky here in Australia that the fact that the infection rates remain low, and mostly that was due to the physical isolation of the country, and because of the measures of restricting international travel came early into use. But having said that, as you said, it is very important that every province assesses their local situation and infection rates before introducing any measures. So in our laboratory, therefore, we didn't have to do much since the infection rate was low. So what we tried to do is try to limit the positive patients from coming through the door for treatment and getting our staff being infected. So that required, first of all, proper education, and that required education not only towards the patients with statements and consents and their obligations was important, with stating also that treatment could be postponed or cancelled, but also taking precautions to the staff, introducing the triaging for everyone, entering the clinic on a daily basis, and that doesn't only include the patients, but every member of staff, from embryologists to cleaners, everyone that enters the doors needs to be properly triaged in order to be able to mitigate that risk, to reduce that risk, and to stop that infection from coming through the door of the laboratory. So therefore, the measures that we took were mostly having to do with social distancing rules and the way that we communicate with patients. So we had basically tried to find all the points of contact that we make through the patients, with the patients, from the beginning of the treatment until the finish of the treatment. So we tried to reduce all the unnecessary steps by using telehealth, by spacing the lists out, by not allowing partners to come for treatment other than the specimen collection that we still consider that is very important in terms of timeframes, and not having waiting rooms. So we have taken out all the waiting rooms. Of course, it is very important to follow hygiene practice within the laboratory, especially since we do consider that infection between the staff can be a major problem in the COVID era. So we not only have to be cautious about the patients and whether the patients are affected, but if staff gets affected, that's a major problem, because then we have to find ways of running the lab. So hygiene control within the laboratory and good laboratory practice is very important. So we have increased that a little bit. Of course, always it's important to have good hygiene within the laboratory, but in terms of the workstations, how they're being used, whether they can be allocated for a single person throughout the day, or whether they have to be reused, cleaning in between. Same for workstations with computers if we're using. So all of that came into use. But also in the waiting rooms and in the other rooms, furniture had to be replaced, everything that was non-leather. So anything that can cause unease in terms of cleaning had to be replaced. So what I'm trying to say is that, yes, in Australia, we did not get hit that hard. But if you're in a situation that you need to take additional measures, then it is very important to review how those measures can affect your outcomes and your success rates. So it is very important when you introduce those measures to have in mind what kind of an effect they can have towards the gametes and the embryos. For example, wearing gloves is the first PPE that comes into use with the masks. But how does that affect the cooling rate of the embryos? How does that affect the dealing and the handling and the skills of the embryologist? Do we require to go through a training curve? How will that affect? Because at the end of the day, our main purpose is still to culture and nurture those gametes and embryos. And of course, having caution about the COVID comes also into place.
Yeah, so thank you. So that's the most important from what George has just said, that it's rather than worrying about the virus only, it's also important to remember that the processes are as important. And what we take away from what George just said, that triaging in order to limit the risk of positive patients coming into the laboratory is not just vital for patients, but is equally important for the staff. And this is something that we are seeing now as labs are opening in the city of Delhi, that this is the problem area where it's not the patient, but the staff, which is more likely to getting infected, and we hear about it on a daily basis. So its triaging is not just for the incoming patient, but it is equally important for the staff. So thank you, George, for those excellent views. We'll move on to the next question, Ved.
So the second question is for George. What is the prevention and control management of COVID in the IVF lab?
We can, since George, you've just spoken. So Sarapreet, would you want to just add something? Wait, we'll just go to Sarapreet and then maybe we'll again take George.
Okay.
Sarapreet, do you have anything to add to any major changes that you think are necessary?
More or less, Pranay has taken a wonderful presentation and George has kind of summarized, but I would just like to touch upon the broad points. Principally the new changes which we have introduced, they are done to protect the patients and staff and minimize the chance of spread of COVID-19. So if you triage the patients as well as the staff, like in our hospital, what we are doing is right at the gate, we are doing a thermal scan, and there is a counter where they are asking, there is a questionnaire which goes on for all the patients as well as the staff who are demonstrating a higher temperature.
Mm-hmm.
Then the services are also all rearranged. If you look at, there is a lot of emphasis which is laid on sanitization, distancing. The seating arrangement has almost been changed. We're also using our auditorium to seat patients, which was never utilized earlier, just to maintain distance. And when they are called in, they come from the auditorium. So that is all, because we can't control their movement into the hospital. Some will come with appointments, some are walk-in patients. So utilizing additional spaces, it's summers in India. So why not utilize the auditorium, and why not utilize the lobbies and put some chairs there? Okay, and the staff management is being done. Husbands are being called only when required. They are coming on the first visit, their semens are analyzed, and then they are coming. What we are doing is we are freezing all samples, all husband samples, after testing them for COVID. So they are not required to come afterwards, and then the chance of acquiring COVID due to any contact or any subsequent exposure in due course of the stimulation is also eliminated, because we can always go back to the frozen sample.
So Sarapreet, are you also freezing the semen samples?
Yeah, we have a separate container which we are using to just clean our containers, and we used to transfer samples in that container, clean the better ones. So we're fallen back to those containers, and we are freezing all the samples in separate containers,
so that you don't have to repeat a COVID test at the time of aspiration.
Yeah.
Yes,
Because patients have some issues with spending 5,000 rupees every time they get the.
Yes, that's true. George, you wanted to add in something?
I just wanted to ask Dr. Sarapreet if do you think it's recommended to prepare the sample prior to freezing, or you don't think that is necessary? If you're having it prepared first through the gradient, let's say, just to minimize the risk of.
We are washing the sample and then freezing it. That is what you're asking?
Yeah.
Yes, that is what I'm asking. Yes.
Yeah. Then again, we have introduced a lot of changes in the consents. A lot of counseling has come in, because the potential risk involved in continuing with the fertility treatment, and the patient has to pay for the COVID test. All those things have come in. The patients are being counseled on a good code of conduct, that they have to maintain a very limited and kind of socially isolated lifestyle for all those 14 days, husband as well as wife. And it makes sense to test husband and wife together, because
right.
It just validates the test all the more. Even the sensitivity is less. We've also introduced HRCT lung for the wife just a day prior to the pickup. Mm-hmm. And we are giving them 1 day of free admission also, just to minimize their contact, exposure time.
This is because we understand there is a huge false negative aspect of the COVID test also. So great. So in addition to social distancing, which was emphasized by George, what Dr. Sarapreet is saying is that a lot of counseling also needs to be, now a major factor in trying to treat patients in this era. So, okay, having heard that, now let's move on to the next question, and Ved can take that up.
What is the prevention and control management of COVID in the IVF lab? From George.
So every laboratory should consider what actions they should take based on guidelines issued either by authorities, government, state, and also the situation of the COVID in country and region. So in Australia, we have such an authority for reproduction. We follow the Reproductive Technology Accreditation Committee guidelines. And those guidelines have stated that we have to follow two things, is to minimize the number of visiting the clinic and to maximize patient protection and avoidance of the OHSS, especially when it comes to the hospitals being loaded with potentially high cases of COVID. Then having a patient having OHSS at that time would be having a lot of additional risk. So minimizing those risks. But in every region, in every country, there is different situations that we need to do. So when it comes to processes and management, it's all about risk. So what is the risk, and how can we control that risk? So there is a tool that we use, and it's called failure mode and effects analysis. And for those that are not familiar with this process, it's basically trying to identify ways that our system and our processes can fail, and those effects that are the ways that these failures can lead to consequences. So then we have to find which are those contacts that need to be discussed. So there are different points of contact between staff and patients. We have to identify each and every one of those. There are situations where staff members can be affected. And it could be that patients don't want to, let's say, postpone their treatment. They might be knowingly having a temperature, having some medication, or trying to drop that temperature just to not avoid cancellation of their cycle. So those are things that potentially could be risky. They might say that we cannot afford going through another cycle. So for those patients, we need to find how we can solve that. So we need to give a score. So the way that the FMEA works is that we have to identify how severe that could be, how possible it is for that to occur, and how possible it is for us to detect it. And we give a scoring. So we then identify, we give a priority number, a risk priority number, by multiplying those values that we give from 1 to 10. And we take into action what changes can we do to limit and reduce that risk to a low level that it is acceptable for us to function. And we have taken certain steps in order to bring that risk priority number down in terms of being able to mitigate that risk and reduce that risk. Also, another tool that we can use in terms of the management is having escalation charts. So what happens at each and every different scenario? So what do? We have to cover all possibilities. What a person gets positive at the triage station during ultrasound, if it's during ultrasound, or if it's during OPU, or if it's during embryo transfer, there is different processes and different steps that we have to do. If we suspect a positive test, do we cancel them? So the temperature of 37.5 has been established as the temperature that we have to monitor at. And what we have asked our patients is not only triage them with those thermal thermometers at the door, but we have also asked them to actively take temperature readings at home. Same for our staff, with most sensitive thermometers that can be a little bit more accurate. So just an example that we see here: what if a patient during ultrasound has symptoms and has been in contact with someone that presents with a temperature? We can carefully manage or postpone, and in the meantime we can test for COVID. If their heart rate is normal, we can again postpone or carefully manage. So it is early on in the cycle, then we can do that. If their heart rate is abnormal, then we can take them to emergency. However, if they have tested positive more than 10 days ago, and they have acute symptoms more than 72 hours ago, which means that they have passed through the rate of infection, then we could potentially treat those patients. So again, This is just an example, but during different escalation charts, during different time intervals, we would have different processes. And also a couple of other things, I don't think they're on the slideshow, is we have to reflect all the changes that we do in our SOPs, and Dr. Pranay did mention that in his talk, very detailed as well. And another thing is, I think that nowadays pandemics come into the disasters management planning as well. So what can we do to avoid a possible disaster? So what if, for example, our situation in the laboratory or in a hospital system does not allow, let's say, the guys that come to fill our tanks? Do we have spare liquid stored? Do we have available tanks that we can move the embryos into? So all of these possibilities of staff being sick, of media not being able to ship in, have to be covered carefully. So in terms of the disaster planning. So these are just some tools that we can put into place.
Yeah, thank you, George. George, I'd just like to understand one thing here, that so this is, so you basically triage a patient every time he comes in?
Every time.
Whether it's for an ultrasound or a blood test or
every time. So in most of the hospitals in Australia, and that applies not only in hospitals but other workplaces. Let's say in the hospital we are based in, most doors will have someone based there at the station, right at the door. So no one is allowed to enter the door until they have been properly triaged. And then once they pass successfully that triage station, they will be allocated a color-coded sticker for the day. Every day is different, to know that that person has successfully passed the triage and it's okay to work within the premises of the hospital. So we do consider that to be the most important part to limit the disease. But again,
as you've mentioned here, the ultrasound, so what you're looking for is only symptoms, or if the patient is in contact with anyone who has symptoms. So which means that you only go ahead for COVID testing if there are symptoms. In an asymptomatic person, you will not do COVID testing.
Yes, just because based on the test that we have done in Australia, I think it was, I don't know if I can get the number correctly, but at some point it was 1 in 100,000 tests coming back positive if asymptomatic. So that detection rate is extremely low. So it wasn't necessary. And in terms of the triaging, we ask 4 specific questions. So the first question is, are you feeling unwell? Do you have flu-like symptoms, a fever of 37.5 or over, cough, sore throat, shortness of breath? The second question is, have you been diagnosed with COVID-19 less than 10 days ago? And do you have acute symptoms in the last 72 hours? Okay. The third question is, have you been around with someone diagnosed or suspected to have COVID-19? And the fourth one is, nowadays we don't ask that because it is not allowed, is how you have you returned from overseas in the last 14 days. So those are necessary for the triaging. Again, language barrier could be an issue. So that is also a situation. Could it be that someone comes and doesn't understand what they're being asked? So all of these have to be carefully put into the planning and the FMEAs.
Well, so this is very, very interesting, but I was just wondering that, does it really, will it hold strong in a country like India, where we are hearing every day that 80% of our COVID positive patients are asymptomatic? So that's something that, but I think our government is also taking a position where because of, a limited availability of test kits, we are going to only test symptomatic patients. So let's move on. Let's move on to the laboratory now. And we've posed this question here because we keep hearing and we get queries about the ventilation, the prevailing ventilation systems. As Pranay in his presentation told us that, clean rooms and 30 air exchanges per hour is what has been recommended for the culture rooms. We know as a reality in India, this is not the case. There are majority of the IVF clinics and the culture rooms, they do not have dedicated AHUs, and they do not have such high number of air exchanges. So I'd like to ask Sarapreet that in India, where most centers, they probably depend on singular air purifying units placed within the laboratory. Now, is it time to upgrade the ventilation systems, and why is it necessary to do so? And is it time to retrofit your labs with new HVAC systems or positive pressure systems? So we'd like to know.
Yeah, so Gaurav, as I understand, the question is about upgradation of ventilation,
Yes.
keeping in mind the potential threat caused by the coronavirus, right?
Yes, yes.
So the virus can either be spread by human-to-human transmission via respiratory droplets, or it can be a contact with aerosol infected surfaces, right? There is no third way the virus can be transmitted.
Yeah.
And New England Journal of Medicine, they have stated that SARS COVID virus, it can persist for 3 hours as aerosols, right?
Mm-hmm.
So if you look at the existing system of air purification in various labs, so either I've seen people, because I do travel and audit labs, so either you see there's a split AC in some of the labs, along with they will have a Coda tower or a portable air purification system, or they may not even have that.
Okay.
Then people have LabGuard, which is Indianized AHU, you can say. It just recirculates air, and there is an option of creating a small window in the utility room whereby fresh air can come in. But mostly people will not create that. It's in a crammed up space, the utility room. So that option is exhausted in most of the places which I have seen.
Does it also provide a positive pressure, a kind of positive
pressure?
pressure?
A positive pressure, yes.
Okay.
But then it's difficult to quantify, but they claim 23 air changes per hour in a 100 square feet area, one lab guard, right? And then there is an air purifier which just recirculates, and in the process it cleans the air of VOCs and particles. Split AC will only recirculate air and will not clean the air. So what people are doing is they are adding this split AC in the utility room in the lab guards, and then pushing the recirculated air which is coming from the split AC and filtering it through lab guard, trying to create a positive pressure as well as trying to create clean air which is free of VOCs as well as particles. But again, if you look at COVID,
will this help remove the aerosol, the suspended aerosol?
I'm coming to that.
Yeah.
So how do you reduce the spread of so-called COVID or any other virus, right? So either it can be by diluting, trapping, or inactivating the virus. 3 things are important, right? So diluting, you can increase the ventilation, which will help in dilution, increase the frequency of air changes per hour. Okay. Then or you can, it's preferably you flush the building with some fresh air, especially if you are restarting the facility after a month or 2 of lockdown. But how much ventilation is protective against COVID-19 is unknown till now. But general common sense says that more ventilation will reduce the risk of airborne infection. Second is trapping. HEPA filter, which is 0.3 microns. It is like using a pigeon net to trap a 0.1 micron size virus, right? So it won't help. So the points which I'm discussing, listen to them carefully, because the same apply to AHUs and HVAC system also.
Okay.
They also have a 0.3 micron size. So either you decrease the pore size now to 0.1 or something, which will again cause a lot of pressure drop. If you decrease the pore size, it will lead to a lot of pressure drop. So your positive pressure may not be maintained.
You mean the pore size of the filter?
Filter, yeah.
Okay.
Either you decrease the pore size, or you increase the media. Okay. The third, which is important thing, is inactivating the virus with the use of UV light. So like in our AHU, what we have is we have got 6 UV lights in the duct, AHU duct, which we assume inactivate the virus if it is coming from recirculated air or some fresh air which is pumping through the damper. Okay. The second technology, which I will not name any company, but it's an ultra low energy plasma technology, which you can see on the net, Defend 150 and all those things, which have been demonstrated to control SARS-CoV-2 by 99.99% in 15 minutes. And fortunately, we have 1 unit installed in our lab. Just a matter of chance, I'll say. We never knew that COVID is going to come and this will be of any help. And neither we can validate that in our lab. Whether it is actually helping or not, it's not known. Then there is a live air system, which I saw on the net. Details I have written to them, they have not responded. The fourth is Zandir purification system, which is offered by Hamilton Thorne. It does have a high output UVC lamp.
Yeah.
But if you look at the website, it is effective against molds, bacteria, fungi, but they have not mentioned even a single virus, leave aside COVID-19. Okay, they've not mentioned even a single virus. So no study has been done, no surrogate has been taken. So it is again difficult to validate any of these systems. HVAC will offer you positive pressure as well as humidity control. Humidity control is extremely important because the virus will evaporate if the right humidity is which is conducive for virus is not available to the virus. The virus will evaporate and it will fall on the surface. So that is why you need to clean the surface frequently, because if there is a virus, it will fall on the surface, right? So at the same time, the positive pressure which is being pumped in, it increases it spreads the virus to a long distance, So if there is a virus, it can infect, it can go and, it can kind of, travel large distance and get stuck to some other person. This is all hypothetical situation. Nobody can see it happening.
That you can take care by constantly cleaning the surfaces. So what's very evident from what you say is that probably increasing ventilation is the easiest, is the most effective probably to get rid of any aerosol or any virus in the air.
Let me complete. So there are, but if you look at the literature, there are some recommendations by Mohammad Fauzi, it's right on the ASRM website, where they keep the HVAC and laminar airflow also switched off, because they're all aerosol generating as well, if you're working in a laminar, or if there's a huge gush of air, they're also aerosol generating procedures. But then at the same time, there is hardly any evidence of COVID in follicular fluid. So even if they are aerosol generating, to my mind, we should not switch it off, but they have recommended to switch it off. And I've spoken to some lab managers in big corporates, they do switch the laminar off nowadays, as well as the HVAC system off when people are working, and they will keep it on when people are not there. So we can discuss that in due course of time.
Anyone wants
to my mind, let me just summarize 12, 13 points, and then you can take the stage. In my mind, the best option is to, we have to understand that people entering the IVF facility would bring in infection. Patients and follicular fluid is very unlikely to bring in infection. So you should always, especially our nurses and all, they go to various OTs, in big corporate hospitals, and they come back, so they might be asymptomatic carriers, So everyone should wear N95 mask, everyone should wear PPE, and you should prevent high traffic in the lab. There should be an absolute restriction on the number of people who are entering the IVF, OT, and lab. You should assume that everyone around you is positive and maintain a safe distance. Most of the embryology procedures can be done without the aid of a technician. It will be a little labor intensive, but it will definitely, there will be no safety concern. If I can, make the dishes, go in and denude, again come out, and go in and do the ICSI, something like that. It will be labor intensive, but that saves me from any exposure with any
Sarapreet, I'd like to cut you here. We are going to discuss this in the next question. So thank you very much for giving us an overview about what kind of air filtration is desired. If anyone else wants to make a point, Krishna or Dr. Sanjay Shukla, then you're please welcome to. Otherwise, then we'll move on to exactly what Sarapreet was just mentioning here. I'm going to pose that next question.
Just 1 second. So the point is, do we really need to upgrade? Is it really going to help us?
All right.
So what is the view of the panelists on this, I mean?
Upgradation is not possible because you can't, it's not easy to get the ducting system. If I don't have an AHU, I can't be getting the AHU done. So we
can do it. We have done it in various.
That's a lot of work. It's not like buying a unit and keeping it. So, upgrading to an AHU isn't
very
just like buying an incubator and keeping it in the lab. Doable, but I think when already most of us are struggling to retain our businesses. Trying to say that get an AHU done might not be a practical suggestion to make.
Shut down for a month.
Well, the way you've said, the UVC light or the plasma technology, there are quite a bit standalone units which can be added on to your existing air filtration system. I think Sarapreet has really put it very, very lucidly and simply. So I think everything is covered up.
Testing and triaging will do it for you.
So that's a great message, because that's what I gathered from George, that we have to reduce the risk of the virus coming into the lab in the way of patients and staff. That's what Sarapreet is also emphasizing, that rather than trying to upgrade our present systems and trying to introduce ventilation and HVAC systems, which may not be practically possible for most people, you have to go the other way, where you have to make sure that there's social distancing and the virus doesn't enter through the nurses. So Sarapreet mentioned that through the nurses who are going to getting exposed in different areas of the hospital, they are huge sources of bringing so in our laboratory, we've made a rule that no clinician or nurse gets into the embryology lab. So they are the ones who are exposed to the virus. So the only way to keep the embryologist free from any form of contact is by absolutely no intermixing between the two. So great. Thank you very much for that point. Yes, George, quick point
just a quick point as well. Like a cheap solution as well would be like a use of single-use scrubs for embryologists entering the clinic. So not scrubs that have been touched by the people that bringing in and available in drawers. So single-use scrubs. So things that are single-use, only wear. So leave your clothes away, different changing rooms, only enter the lab for staff that are working there, just to limit what goes into the lab. So whatever goes into the lab will recirculate. So try to minimize things that come into the lab, will minimize the virus as well.
So Ved, you can take the next question now.
Very important question for Krishna. What are the working logistics for embryologists in big lab with large workload? And what are the precautions one should take clinic with a single working embryologist, where only single embryologist there and some time that embryologists get infected? So how to go about that?
So the first statement I would want to make is, there's a lot of mental pressure that we guys are creating for ourselves, saying that, okay, I've got a big lab and there's going to be a major issue. I think when we're talking only about an embryology laboratory, the amount of aerosols that are generated with the processes we do is very, very limited. I think when the clinical team, the anesthetists, patients, nurses, for them, of course, we've been discussing there are a lot of challenges, but when it comes to embryology, we've always been trained to actually plan our work. For just to see tomorrow if there is a list of 10 patients, a lot of thought process goes in the previous day as to know who's working at what time, who's coming in, who's going out, where to keep which dish, incubator management. A lot of this planning is happening, and I think over the years as embryologists we are trained for this. So I don't think it will be a big change in the practice for embryologists when you start working. But there are challenges. We run a unit which has got 12 branches, and first we didn't open all the 12 branches at times. That was the first thing. We said, let's not open all the branches at once. Let's go in a phased manner so that we learn from the experiences that our team is having, and it makes it easier for my other laboratories. That was the first thing. And then we made SOPs, and we actually looked at can it practically be implemented, whatever we are saying. There was at one point, one of the embryologists said, no, I think we should be making sure everybody wears N95 mask or a face shield and work. And that's practically impossible when you're doing your ICSIs or egg collections. The amount of fogging that you're going to get, and with a face shield, that's impossible. Whatever we do is under microscope. So we did have a lot of debate, discussion, because we wanted to make sure that whatever SOPs comes in are scientific. At the same time, it is user friendly, and the team would actually implement it with ease. That was also kept in the mind. So it took us 2 or 3 weeks to get the team, get used to follow those newer little things that we had brought in the laboratory. And one of the things that we all were talking about was wearing the gloves. I think usually in the embryology laboratory, except while we're doing an embryo transfer, rest all times we leave it to the embryologist whether to wear or not. We leave it to them. They just wash their hands and come. But now I think it's mandatory that they change the gloves, and they keep on changing it quite frequently. That is something, and that is a little change in the practice, and people sometimes find it very difficult to follow it. The next thing was avoiding crowding of lab staff per se, because in the bigger centers, they have at least 4 centers where there are almost 6 or 7 embryologists, and we said all of them are not going to be inside the premises, though the laboratory area is quite big. We said at any given point in time there are going to be only 2 people, and the rest are like working in shifts. Since the shift or the rota is put in such a way that whoever's doing the collections and dishes are coming in the morning, and then the people who are doing the season freezings towards the end of the day, and then there's another 1 or 2 people who are doing the daily QCs and paperwork, and then going. So we're kind of working in rotations. So that's kind of avoiding the lab crowding. We've absolutely locked the door of the laboratory. There's a usual practice of everybody wanting to peeping into the lab. Clinicians, nurses. I've had the housekeeping staff also wanting to get in to do a lot of things. The embryologists have been told that the housekeeping staff is going to enter the lab at the end of the day. In between whatever cleaning for whatever reason is needed, the embryologist is going to do that. And this is for the safety of the lab staff, and everybody's agreed to do that. So avoiding crowding of lab is something that we've looked in. Restriction of people moving in and out, to an extent that they're clearly told that have adequate water, use the washroom, because the next 3 or 4 hours the embryologist is not allowed to get out of the premises. The IVF lab and OT to that, because normally, because we are a standalone only IVF unit, we do not do any general other hospital work in our this. So we usually walk with our scrubs in the floor. We don't really restrict them from changing. So, but now I think we are very particular that once they actually more of the main IVF theater complex, again they'll have to be changing in, or they're wearing something protective that could be removed. An air shower is taken, and then they're getting in the lab. So they are kind of restricted and locked in the lab. That is how we were restricting the movement of people, because we don't know what they're going to carry in. Orientation of the lab staff. I think this is something that has taken time. We keep doing this on a weekly basis. We actually conduct small little tests for our lab staff to check whether they've understood the do's and don'ts. And sometimes we are surprised that small little things people are still taking time to understand, and this has taken some time for us. We're limiting the number of cases, though our laboratory, the big ones at least, are well equipped to handle 8 or 10 pickups in a day. We have restricted it to 4 in the bigger labs. As George was saying, bring it down to 75. We have made it 50%. So whatever it's been their normal caseload, we say take 50% of that, because we are allowing only 2 people inside the laboratory. And then do you have only one theater? As in, there are, at least in one of my other recent centers that we opened up, considering the huge caseload we have a separate transfer unit, we have a separate pickup lab, and an additional OT given out there, because we were doing around 10 pickups on a daily basis there. So if that is there, again, a lot of manpower and planning is needed. But if you are, most of the centers, even in the beginning, we only had one theater, which was used for egg collection transfer, one laboratory, which probably had 1 or 2 mink incubators. So I think a lot of planning, that is what is needed. And if you could sit and plan and get your workload accordingly, I don't really think it's an impossible task, whether it's a big or a small lab, whether you have only one embryologist doing it, as long as the person working understands what he's trying to do.
Right.
And he's given the space to talk. I think we constantly make sure that, they're given breaks to hydrate themselves, eat, relax themselves. I have embryologists. Even I probably at the beginning used to get very stressed with these ICSI, sometimes difficult cases, and you forget the timelines and you're just sitting with your machine for 4 hours, 5 hours. I mean, this is absolutely a no. And that is where my role off late comes. My job is to ensure I've got them to move out of the lab, go get some fresh air, eat, take frequent toilet breaks. I've
Especially
had
because you've made life more difficult now. You were saying that out of 6 embryologists, you will only have 2 people work at one time, one possibly to witness. Krishna, I would now like to ask Pranay. Pranay, I'd just like to ask, since Krishna said that if he has 6 embryologists, he would want only 2 people to go into the laboratory and work at a particular point of time and perhaps work in teams or in different shifts. What about laboratories where there's only one embryologist, where there's only a single embryologist? What are the precautions? So you have the first-hand experience. So what if the embryologist gets infected? What are the things you will look at?
So to be honest, pre-COVID or COVID, it would never be one embryologist in a lab. You cannot have a person doing just procedures and not them being witnessed. That is one thing. The other thing is even for 4 pickups, as Dr. Krishna said, or 5 pickups in a day, it's not feasible, especially when we are wanting to delegate certain responsibilities to one particular person. For example, it has been proposed that there is just one person who is dedicated to doing pickups and denudations and vitrifications and norming, and there's just other one person who's just sitting on a micromanipulator rig and just doing exceeds to minimize the cross touching of the equipment between the staff itself. But if I understand where your question is coming from.
Yeah, so Pranay, I am asking you, what is the risk? Because we know this, that in India, there are thousands of centers which operate with a single embryologist. So please, can you explain what is the risk involved for all these clinicians to be calling a single embryologist to their center?
So I understand, that's what I'm telling you. Your question is coming from the point of view of us having a freelancing embryologist visiting ample number of centers. And there's no stringent way of you being able to do a triage on them having visited 4 or 5 centers in a day. So I don't think so. Your problem begins after the embryologist is in the lab. It begins right before the embryologist is in the lab. I think you having somebody, it's just like a medical representative visiting 5, 6 centers in a day and being an unintended source of the infection between the centers. So you wouldn't be, if you have a visiting embryologist coming in and contaminating your samples or cross-infecting your personnel, you wouldn't be able to pinpoint the source of infection, which particular centers to quarantine. It's just not that particular center that suffers.
And what about centers where there is very limited staff? If they get infected, how do they tide over those times?
I think we have to take a call between.
Everyone doesn't have the luxury of multiple in-house embryologists, but they probably have 1 or 2. Then how do they get over the problem?
I think that the embryologist who's
tell us about what you do with
with
Gaurav Khan. You provide backup.
Always, no, it's never you being alone in the center in the lab. That's for one.
Yes.
But in case if you're a couple of embryologists and both of one has tested positive and the other is being quarantined because of being in close contact with the embryologist, you have to have good amicable relationships between other embryology friends in your community to act as backup. But I'm pretty sure that a facility wherein you have an infected person coming in would rather be looking at finishing their cases and shut down for whatever period and quarantine their rest of the personnel rather than carrying on their operations.
Okay. Thank you, Pranay. Now, I'd move on to the next question for Dr. Sanjay Shukla. So now we want you to throw light on, the fact that whether it is preferable to have in-house embryologists or visiting embryologists in our country at this point of time. And we want you to spell it out for everyone who's hearing, all the clinicians who are listening to this panel discussion, that what is more vital, in-house embryologist or visiting embryologist? And what is your advice for clinics who do not have an in-house embryologist?
Well, Gaurav, having an in-house embryologist is a prerequisite of any good IVF clinic. In fact, it is mandatory in many countries. Unfortunately, this is not a practice in our country, but in recent years, more and more clinics have realized the need, and now they are recruiting in-house embryologists. However, there are many centers, as you mentioned in earlier question to Pranay, that are either in small towns where they do not get a qualified person with good experience to handle this sensitive and demanding branch independently, or there are clinics who perform very few cycles per month, and for them having an in-house embryologist like the qualified one seems an unnecessary, I mean, this is in quote, unnecessary financial burden. These clinics mostly do batch IVF. So in present scenario, planning batch IVF with a visiting embryologist poses serious challenges, as you already mentioned. And in case of some adverse incident, may have even more serious consequences. Therefore, I would reiterate the importance of having an in-house embryologist. But for any reason, if the clinics cannot have such a key person in their clinic, they should have access to someone, as Pranay mentioned, in nearby areas who can be easily brought to your place by surface transport. I emphasize on this particular thing because it's easier to send a car and bring him in your laboratory. And who is available to carry out your work? If he is also busy, everything will be ruined.
Yeah, Delhi, Bombay is not going to work anymore.
So further, I mean, even in those clinics, as you asked in the previous question, who have all the necessary staff in-house, they should also have kind of tie-ups between other clinics of the town or in the neighborhood to act as a backup support in case something goes wrong. And the authorities seal the building and the whole team goes in the quarantine. This can save you and your patients from a greater catastrophe.
This is something which happened in Delhi recently.
Yeah.
With a hospital where majority of the staff was tested positive and the building was sealed.
That's right.
So that's
like,
very interesting. Yeah.
That the question that you asked to Pranay, like Pranay, I am also a single embryologist in my clinic, yeah. But like we have at least 4 or 5 embryologists who are in tune with others, so that if anyone needs any assistance from the other one, he can act as a backup.
So great. So that's what we understand, that backup is very important. Yes, Sarapreet, please go ahead.
We feel all clinics should have some kind of a liaising with a neighboring clinic. Recently, the borders were sealed, and one of the doctors, she was from Gurgaon, the patient was from Gurgaon, said that they just couldn't go to Delhi. For the clinic was in Delhi, so they had to bring their patient to us. Tomorrow also we are doing a patient who, by some circumstance he has come to us. So good relations are very important, especially at this time.
Yeah, so that tends true for not just the embryologists, but for the clinicians also.
Yeah. That's true. That's true. So that's a very important take-home message for everyone watching, that now please, this is the time to start creating backups as far as both clinical as well as laboratory backups are concerned. Ved, you can take the next one.
Next question for George. Does the embryologist, if operating nowhere in the near vicinity of the patient, need to start wearing PPE while doing laboratory procedure, such as semen processing, Igg and freezing? what is the level of protection required for George?
Okay, so first of all, at the point of contacts with the patient is very important if we have those. So for example, for semen collection, it is very important to do that. However, we have to know that what is routine anyways is that every time we're handling bodily fluids like seminal fluid or follicular fluid, we are wearing gloves and in some laboratories masks as well. That's prior to COVID situation. So the way I see it, there is 3 points that we need to address. Is it possible and is it the risk to have transmission from patient gametes to the embryologist? Is the concern the staff-to-staff transmission, or is it the transmission from staff to the patient gametes and embryos? So we know for the first point that even though some COVID sample has been identified in semen, however, following the sperm washing, that viral load is low. So we have to be precautious when preparing the semen at the beginning. And during the replantation and development as well, the embryos have not yet demonstrated having COVID. So the use of PPE in the lab for protection of the from gametes and embryos should not impose a real concern. But we have to consider that it is a possibility that a member of staff, and we covered that extensively, I think, in this webinar so far, it can be affected and therefore being asymptomatic infect other embryologists. So everything that was mentioned previously, like the space in the laboratory, assuring social distancing, using identified hoods, having teams, and also how do we clean in between the switchovers becomes really, really important. So it's not just we have one team, then leaves, then the other team comes in. Is how do we make sure that we have cleaned adequately before the transition to the other team? Also, if you're using an electronic system, then that basically identifies that one solo person can be in that proximity. If not, then of course you have to wear PPEs within the lab for the protection from staff to staff, since we're not keeping the distance. So there need to be backup plans for embryologists, and we have to have our specific plan is that because we cannot have two teams, and we do require that in-house embryologists, we consider that to be very important. So therefore, we have allowed one person of staff not being in the circulation at any given time, and this is changed weekly, therefore covering the asymptomatic period. And in case we get someone gets infected and spreads the virus within the laboratory, we have that person to come and rescue by freezing the embryos and gametes for everyone that is on culture. So there are solutions. It's just a matter of thinking what staffing, what spaces, what facilities everyone has, and what actions they can take in order to limit those effects. So then again, for the third point of transmission from staff to the patient gametes and embryos, of course, we do use good hygiene practice throughout, and we have to be particularly important when making dishes. And of course, the gloves during that step is considered important. But it's not about when do we use PPEs. I think it's very important to educate the staff on how do we use the PPEs. So how often? What's the mask? How long can they be sustainable for? How do we put it on? How do we switch it? So those things can sometimes create more of a risk of transmission rather than decreasing it. So no proper use and not proper education can also impose a risk. And for us in our center, we have made it mandatory for people to watch online training seminars about the proper use of PPEs, how to handle, how to use, how to properly dispose. So all of this needs to be taken carefully. So other than PPEs, as I said before, single-use scrubs and avoiding of anything that comes into the lab to be able to go outside and bring it back in.
So what I understand is that you are advocating the use of single-use scrubs and gloves and a mask. Are you advocating the use of an N95 here when we talk of a mask?
So in Australia, not, but then in situations where the risk of transmission might be higher, then it could be something to be considered. But it's also the availability of such masks
Yes.
whether they have been tested, whether they can be provided. And if you're providing to all your staff one of those masks that need to be replaced every few hours, how many of these masks will you need to use over a period of month? Are those masks being available through your ordering system? For example, we have capped our needs based on previous buys from the government, just to make those masks available where they're actually needed, in terms of high risk, when there is aerosol generated procedures where the risk of transmission is actually higher, and then going downwards, being in an IVF lab setting where actually the aerosols being generated are not that high, then it's not actually that required. So everything has to be taken into the equation. Of course, if you want to take every precaution, but how easy is it to use microscopes with the N95 masks? Is it easy to use? I haven't used it personally. So if anyone has, is it easy to use?
I have worked completely in N95 mask. It is doable, but I am so glad that you made this point, that IVF laboratory actually is a low risk setting in terms of aerosol generation and acquiring the virus from embryos or gametes, or transferring the virus to embryos or gametes of patients. The only place which seems difficult is staff to staff transmission, which applies to any laboratory. So if we are obsessing of PPEs, and that's why there were so many questions even before the panel discussion started, where people are continuously asking about what is the level of protection required for embryologists. So it is, if you have to wear an N95, then it's perhaps only to prevent staff to staff transmission, and it has got nothing to do with the other two modes of transmission.
And another thing we haven't mentioned is not necessarily having to do with PPEs, is for the actual staff as well to be following isolation as much as possible. So social distancing and avoiding gatherings, and all of that becomes so important. Because even with the use of PPEs, it doesn't zero the risk.
Yeah. It doesn't. So that's a great take-home message, that PPE is not probably the most essential part of the embryologist attire. A normal mask and gloves and a single use scrub can do it for them, but it's the other, again, the social distancing, the isolation, that's what's going to save you. So all right, now okay, so we took this question for George. Okay, now I'd first like to ask Krishna about what is your emergency plan for operation of suspected cases. And why we ask you this is because despite all the triage and all the COVID testing in certain settings in India, we know that a lot of patients are going to slip through this safety net of triage. And at the last moment, we are going to find out whether they're positive, and we may have to proceed for OPU, or we may even never find out. So what is your emergency plan while operating for such high-risk cases or positive cases?
Well, initially itself, I think there's a clear discussion counseling that, patient is actually doing this at their own risk. Consent is taken in their language. And it's very clear that at trigger or at egg collection, if the patient turns out to be symptomatic, or there's a suspicion and we've got a test done and it's positive, then it will be cancelled. Because, there is no way that I'm going to take a known positive patient into the premises and infect the whole thing. Considering the need, I think we're very clear we're going to cancel such patients. So, and reliability of the test is something that we have to question here, and validity of the test. Let's say if I do this test on day 6 or day 4 to be on a safer side, the person could turn out to be positive for some reason at egg collection also. So that's why we said that, it's more near to the pickup. If things go wrong, they're canceling it. But what happens with these people where there is risk of OHSS? PCOs who with very minimal dosage have got some 10 or 15 follicles. I just can't leave them alone. I think we are thinking of doing a follicular reduction for these patients, and it's going to be cancer.
Sarapreet, yeah, please counter that if you want.
Sorry,
Just a suggestion that in our hospital, we are lucky, but I think all big hospitals have many OTs. So it's not a bad idea to, do the pickup in a separate OT, which can be sanitized and, fogged afterwards to take care of the COVID positive thing. And you just bring the follicular fluid to your lab.
Okay. Yeah,
But
Wade, you were saying something?
Because, you have mobile nest and the devices which can maintain the heat, during the transit.
But we are not sure. Yes, the reports are saying that follicular fluid, vaginal fluid do not seem to show the virus, but on the other side, we are not sure about it. So I don't want to get this into the laboratory where other patients are there. And then honestly, though the ACE or ASHRE have said, can you have a separate cryo tank? Running such a big program, I don't think we can still afford a separate new liquid nitrogen tank. So right now we are putting it in a separate canister, but honestly, it doesn't make sense. And such patients, if I have to freeze the embryos, I'm not really sure. There are a lot of questions coming in there, and there are a lot of aftermath
But
that could go wrong.
Krishna, if you have a separate tank, designated for COVID positive patients, then why not go ahead? You're talking about a patient with ovaries full of follicles, possibly a very high estrogen level. Would you feel just safe just abandoning the cycle at the 11th hour?
Well, from a personal point, probably it's hard, and we know how difficult it is to work in the lab. But there are a lot of people who are at a risk: the anesthetists, nurses, doctors. The PPEs what we have. Honestly, I don't think they are the right ones. People are just donning it, but ideally, is it really doing the right thing? And are we really putting them right? Simple thing in my lab, one day I just enter, all my staff were wearing masks, but the nose, it was just covering the oral cavity and not, they intentionally didn't do it, but they were carried away with work and the mask just dropped out. So with an infected patient who I already know is symptomatic and infected, I probably would not want to take a risk there.
Do we have any other comments from the panel regarding this? That will anyone probably go ahead and retrieve the eggs, possibly for freezing them later with adequate PPE protection, or will you completely want to abandon the cycle?
So if I may make a comment,
yes,
I think the clinicians would be better off handling the cycle cancellation and abandoning that cycle without giving a trigger, whether it's a long or a short abandoning cycle. And they probably have certain medications, especially the antagonists, in their armamentarium to make sure there's adequate utilization, and this patient would not. You have to do a risk-benefit analysis of whether this patient would be better off having a pickup right now and infecting so many other patients, or you can certainly.
That's an assumption. That why is everybody making this assumption that a pickup will lead to infecting everyone?
So I'll tell you what in an ideal world would be like you, especially in the UK, where you have certain designated tertiary level ARD centers who are solely handling the seropositive cases. In an ideal world, you would be having a similar scenario here in India, but it's impossible because right now, even the COVID positive pregnant women who are at term, who require hospitalization, are facing a tough time. So I think for something which is considered still an elective procedure for a condition which is not probably a disease for some, there's nobody who's going to be accepting your patients. So for us to be taking a call as independent fertility centers, I think it's a no-go.
Okay, but I would just like to leave everyone with this thought, is that despite the fact that once you get a positive on paper, and you were very happy to proceed with a negative on paper, 4 out of 10 patients that you will be aspirating in your operation theaters will be false negatives, and they will have the virus within them. So, so like Krishna said, that people let their guard down very easily. So the message should be that even though we are trying to make sure that positives don't come into our laboratory, on any odd day in each of our laboratories, positive patients will slip through the safety net. And so we cannot let our guard down. Especially George told us that asymptomatic patients, the triage does not ask you to test asymptomatic patients. So I am sure there will be some patients which will slip through the safety net, and they will end up performing procedures on patients who are COVID positive.
Gaurav, can I interrupt?
Yes, please, Dr. Sanjay.
Another very important aspect related to this is, what if a person turns out to be positive? What could be the reaction of the other patients that are, under process in the pipeline? So how could be those patients handled?
Anyone wants to take this?
Because this could lead to a
I think it
very...
should be part of the declaration, right?
Yeah, so here counseling comes into the picture.
All right, so let's now move on. George, we've probably answered all there is. If you'd like to add something to that discussion about your emergency plan for operation of suspected cases.
I think that we wouldn't take the suspected cases as well. We will lead them straight to testing, and if that testing is positive, then at the time of OPU, we could cancel. So if the patient doesn't go through the triage successfully, then it gets escorted, the patient gets escorted directly to the COVID clinic to be tested, just to avoid further downstream effects and compromising the health of the other staff and the other patients. Of course, all our patients do have to go through consenting for COVID. And there's also a statement that they read and understand that it could be that their treatment could be postponed or canceled due to these circumstances. So they all go with the knowing and the understanding that even at the last hour, this can be changed. So it's all about trying to avoid risking the safety of the other members of the staff within the same laboratory and the other patients as well. So it's not just for the patient, it's also for the sake of the other patients.
Okay, all right, thank you very much. So now we're going to move on, and I'd just like to add in my own 2 cents here that now we in Delhi are not allowed to test asymptomatic patients. So for us, probably everyone is a suspected high-risk COVID patient, and we have no option but to proceed with egg pickup for all of them. Sarapreet, now the next question is for you. Ved, why don't you pose the next question for Sarapreet?
Sorry. So, Sarapreet, there is a question for you that how to go about semen collection, semen disposal, and semen processing in this new era of COVID.
See, first of all, I think educating the lab staff and the ancillary staff, people who take care of cleaning about the COVID-19 infections and the new clinic policies is very important, and it has to be reinforced. I have recorded voice messages which I send them to almost every day, because half of them work on one day, half of them come on the other day. So it becomes difficult to, get them working on the same level. So I send voice messages every day. And thorough cleaning of instruments with 70% alcohol is something which we are doing. Embryology, because our embryology lab coincidentally is on the ground floor and the IVF is on the first floor, so we can afford to use 70% alcohol. It's different floors altogether. We prefer digital records, and we kind of send it through emails and all. We don't print, and we don't keep too much paper in the lab because more people handle, more the risk of transmission. Home collection is, if it is possible, we prefer that. If the patient comes through via appointment, and we have written to all gynecologists that please ask your patient to take appointments, ask them to collect containers when they come for consultations, and they can bring in the sample. But then again, there's a time frame of 30 to 40 minutes in which they have to reach. Fortunately, the roads are vacant now, so most of them are able to reach within that timeline. But if they are staying very far off in Manesar or in Delhi or some other far off place, then we are managing with in-house collection. And we are then sterilizing the lab with 70% alcohol in between patients, all the surfaces, doorknobs, handles, the couch, everything. And at the end of the day, sodium hypochlorite, and again, cleaning is done. We are working with frozen samples, as I've already explained, for IVF ICSI patients, just to reduce the another COVID testing, or that it gives you a sense of security that you're not using a COVID positive patient. Nothing in the lab is shared now. All the pipetters, all pen. Coincidentally, we have 2 microscopes. So one is for one team, the other is for the other team. They come, clean their stuff, and kind of comply with the orders. When we process semen, we are preferring the double density centrifugation. And then the second wash is done with at least 5 ml of semen, media. And then we follow it up with a swim up. We wash the sperm containing fraction again with 4 to 5 ml. So it's like a triple wash. And then we resuspend in the appropriate media depending on whether it is going to be used for IUI, IVF, or ICSI. Semen freezing, again, as George also pointed out, we have to wash the semen as a rule. That is compulsory. You disinfect the outside of all the vials, and before you freeze them. Then you load it with the semen, and then you freeze it. Again, you have to disinfect the devar, styrofoam box, even the tweezers after each use. And you have to store them in a separate container. That is what we are doing because we coincidentally have one. So we are doing it. Another point which I missed on was that we are trying to receive the semen sample from the patient in a container, on which we are, covering it with a simple paper. As soon as we collect the sample, the technician is wearing gloves. He collects the sample, he picks up the container, sanitizes the container, and then he discards his gloves. And again, wears a new glove. And in the meantime, the paper is also discarded. So that is how we are doing the embryology work. And when we are discarding, we are using the same semen collection container in which we keep on throwing the seminal fluid, the used media, everything. And then we tightly cap it. And then we are, placing it. So it's your choice if you want to add some water, saline, or sodium hypochlorite, or 70% alcohol. That's your choice. So, and then we can dispose it in a bag. We can nicely pack it. At the end of the day, all the containers are packed in a bag and discarded as per the hospital policy.
So the idea is, as you mentioned earlier, diluting. This is a form of dilution, right?
Yeah.
What about the semen freezing sample? When you thaw, what you are doing that time? Again, you are washing, or with double density or something else?
No. It's a wash sample. So we're just giving it a single wash in sperm wash media, just a single wash.
Okay.
And just if you want, you can again, just clean the outside of the vial or the straw when you take it out. Before discarding. That's just a double precaution.
Okay. All right. So that was in detail about semen processing and freezing and disposal. Now let's move on to gamete handling and culture, which is again very important. So Dr. Sanjay Shukla, is there anything you would want to do differently as far as gamete handling and culture is concerned in the laboratory?
Well, we have been listening to all the experts since this afternoon, and everyone has emphasized about the good laboratory practices. So in my opinion, in IVF labs, to follow GLPs and universal precautions for handling cells and tissues is mandatory. If someone follows all those guidelines, I don't think one needs to do anything extra from the routine. If you are performing all your work meticulously, observing due precautions, it is very unlikely to have SARS-CoV-2 contamination in your lab as George has emphasized, as Sarapreet has emphasized, as Pranav has emphasized. One thing about the PPE and all that we use in our laboratory, and related to this statement of mine about the good laboratory practices, a very good example can be given from the game of cricket. Everyone is cricket crazy in India, so they can very well relate to this. That
Also Australia.
yes. So if a batsman is equipped with all the PPE, and if his technique is not good, he may have more chances to get struck with a ball than a person who is having better technique to face the balls than having all those gears. So if you are following the guidelines, if you are well read with the good laboratory practices and following those practices in your laboratory, it is very unlikely to have infection in your lab. So it is one thing. And as very clearly mentioned, that our labs are essentially clean rooms. So these are these labs are probably the safest to work in. Again, doing too many cases at a time, not advisable. Double density gradient, as Sarapreet has clarified, would be my choice, process of choice also for this preparation. So nothing extra from the routine, but yes, with all the precautions and following all the good laboratory practices.
Great. So thank you. Thank you for reiterating again. And through the discussion, we've re-emphasized that once the samples are processed and sperm washing and pre-implantation embryo development, the viral load is very low, is very low, as minimal. So there's very little chance of acquiring the virus from there. Ved, why don't you proceed with the next question?
So next question is, what disinfection system can one employ for your culture space, like air, ground, workstation, hands? So many questions are for that. So I think Krishna and Sarapreet can take this question.
Well, I think air already, Sarapreet really took us through a very detailed discussion. Let's not visit that. I think having a proper air handling unit, whichever centralized or a standalone unit, we go with that. Coming to the workstation and ground, we would again go with these quaternary ammonium compounds. But again, this is how, in the beginning we said, after every case, beginning in the morning and at the end, we would do this quaternary amount compounds. And we started having a little odor, and we thought residual was being left. And then we said, unless there is a spill, let's not really do this quite obsessively of using one of these products, USAFE or 7X. There are a lot of quaternary ammonium products that are available in the market right now. So while we opened up the lab after the 2 months lockdown, we did give multiple wipes of this quaternary compounds, sodium hypochlorite, distilled water, all of that. Again, did a little burnout of the lab for almost 5 to 7 days. Now that we're routinely working in the lab, every day in the morning, it's just distilled water. It's just our routine day-to-day practice that we do. At the end of the day, when everything is over, we're using USAFE, so we just take that, we clean our workstations, laminar airflow, and the floor. It's just once in a day at the end of it. So keep it simple. As long as your practices are good, as Dr. Sanjay said, you're following the good lab practices, we are okay. But whenever we have some spillage, I think again we are wiping it with sodium, not sodium hypochlorite, with USAFE.
With USAFE. Okay, yeah. That was refreshing to hear. Sarapreet, can also pitch in, please.
I would just emphasize on two things. If you're using it for surface, I mean the floor, after wiping, after using the USAFE, you have to leave it for 30 minutes. This is with practice which people don't follow. And then you have to wipe it with sterile water preferably, or simple water, distilled water in the case of flooring. Yeah. If you're using it for laminar hood and incubators, just spray it for and leave it there for 15 minutes. Most of it will evaporate because it's a heated stage. But then again, still you have to wipe it with a sterile gauze piece and You can use, mineral tonic, double distilled water or any sterile water you can use. You can wet the gauze with that and just.
So this was one of the reason why we thought in between every case, let's say I'm doing 4 egg collection, we said in between we'll do it, and practically it was not possible.
Only spillage has to be.
So yeah, if it's spillage. So what we are now doing is, we are careful, but what we do is we put that little sheet that comes in the HIV sheet in the laminar airflow. A bit of temperature is changing. So we've increased the laminar airflow temperature to 38 degrees. And then we are working, if at all there's spillage, it's on that little plastic sheet, which can be discarded. The laminar airflow is going to be safe. So we're not using it in between cases, USAFE anymore. Only at the end of the day, we clean with USAFE.
But we have to keep this in mind that USAFE is embryo non-toxic at the end of the day.
Well, that is what they say, but there is some amount of odor.
Residue. Yes, there is some residue. There is, because it's at the end of the day, it's like a surfactant. So you need to clean it, like Sarapreet mentioned. You need to clean it with water, right? Am I correct, Sarapreet?
Yeah. But then in our hospital, the standard time between 2 pickups is roughly half an hour.
Okay.
So USAFE can be safely used, for spillage and all.
George, what are you using as a disinfectant in your laboratory?
Embryo tested sprays as well. But yeah, with the COVID, what I wanted to say is that exactly what Sarapreet just said, that spacing the patients out allows for proper disinfectant, because that's not only for your theater space, it's the recovery space, is the meeting of patients in between entry and stage 1 recovery, stage 2 recovery, exits, all of that. So spacing the patients out, minimizing the number of cases you can work on a day, extending the list in morning and afternoon shifts will give you the flexibility in that time interval that you can do a proper clean in between.
And for people working in Delhi,
comment on Sarapreet, a quick comment on hydrogen peroxide.
6% is recommended, and never used it. Never used it. Anybody who has used?
I can comment on this. He is using 3% hydrogen peroxide.
3% now in CDC guidelines it's 6%. So
even in the Cairo consensus, it's 6% H2O2.
Yeah, well, regarding hydrogen peroxide, I don't see any problem with it. The only thing, probably there are few studies that show that there are some residuals after the use of hydrogen peroxide, is because they have some stabilizer added into it. So maybe those things may remain afterwards, but most of the things like hydrogen peroxide, it turns into the water and oxygen, so it doesn't remain after the use. If you are using it maybe at the end of the day, so I don't think it is as embryotoxic as some other disinfectants could be.
But Shuklaji, another concern of prolonged usage could bring about corrosion, especially if I'm doing it on my laminar airflow with a stainless steel.
Yes. So
there is a risk of corrosion.
Yes. So I would like to use your discretion that on which surface and in which area which disinfectant can be used.
We don't know about the USAFE and the other things, but for now, at least H2O2 might be a potential corrosive.
Yeah, on the metals, yes.
Yeah.
In places
and not only metals. An important point is about the cleaning of your microscope optics. So if you are using something which is corrosive, the whole coating of the antifungal coating and other coatings that are on your optics will be gone.
The glass will become hazy. And I actually did that as a beginner. I had taken 70% ethanol and cleaned the glass, and that's it. The optics had gone.
Yes.
So
Sarapreet, you wanted to say something, Sarapreet.
So Gaurav, I was trying to make a point that in states such as Delhi, in which they are not allowing COVID testing, I think for you guys, USAFE is the best option. You have to space out your pickups, allow USAFE to dry out, and then clean nicely, and then get along with the next pickup.
So it's important to let USAFE stay on the surface for some time and not just wipe it out immediately, right?
Yeah.
We have only 2 minutes left. So we have 2 questions.
All right. But we're not doing too badly. We'll probably overshoot by 10 minutes. So the next question is for George. Thank you, Ved, for reminding us about the time. Thank you very much. George, so as far as cryopreservation is now concerned, any changes in terms of protocols or storage facilities that you recommend?
All right, I'll be quick because during this discussion we cover most of these aspects anyway. So when every time we change a process, we have to be cautious about validation and assessment in our own setting, and expenses, of course. So changing the process of cryopreservation can be costly. Again, we did say that due to the extensive washing, the viral load should be extremely low. However, we still have to be proactive and take some measures. So either we're using vapor phase, that could be one solution if any have cryo tanks in their position. But if we're using wet tanks, then absolutely use of closed systems and high security straws, and that are free of any danger of contamination. If we want to switch from an open to a closed system due to COVID, we have to validate the system and the learning curve and be able to examine whether that can be a successful switch for our laboratories. Again, risk to benefit has to be carefully evaluated. And everyone has mentioned that if we're freezing semen, that has to be washed thoroughly prior to be putting in high security straws. However, if we're not doing any of the above, then using a separate tank for high risk or positive cases should be considered, and it is actually recommended. So if we're not using high risk straws, or if we don't have vapor phase cryo storage, then probably all the positive cases need to be put in one tank solely dedicated for them.
Yeah, but how will we reach the positive cases? Here, nobody's ready to proceed with the positive cases. So I'd like to ask you that. I want to ask you.
It could be the possibility of cases being picked up after OBU. It's always the case that someone presents with symptoms after OBU, and during that 5 days of culture, we could flag it up. So if that is the situation, what is the possible solution? Again, the easiest solution would be to use high security straws and have peace of mind. But if that is not the case, having a tank that could be the spare tank for that minute and disinfecting it afterwards. So yes, it could be the possibility within that 5 days that some of the patients might be diagnosed.
So that 5 days gives you that window. But
Yes.
now the very reason why I asked this question on this panel is because, and I'm thinking that if I am thinking about this, then I'm sure other people are also thinking about this possibility. What are the chances of, and I want you to give, an answer which objectively, which is logical to you. What are the chances that there is a virus sticking to an embryo which has been placed on a device, a vitrification device, which has been plunged directly into liquid nitrogen and then capped? For example, there are many such devices like Cryotech, Cryotop, and so on and so forth. I'm sure everybody understands what I'm talking about. For those to be capped, so these are probably semi-open systems, if I would say, for them to go into a liquid nitrogen tank, and then what is the realistic chance we're talking here about infection?
I would ask you this question with a question: have you experienced that to be an issue with any other viral transmission diseases?
Not to my knowledge as of yet. Thank you very much for asking that question. And that should be the important take-home message here. Sarapreet wants to say something.
One thing you can do is when you freeze in a cryolock or any other device, the remaining LN2 should be discarded as a safety precaution,
Yeah, that could be the safest thing.
Yeah, because ultimately, if there is some load of virus which is shedding and you're constantly pouring it back, so the virus load might accumulate. That's just a theoretical point.
Yes, so that makes sense.
But and keep the embryos.
Yes, so at least we are not telling people to go go back and scurrying for new tanks, and because that may not be possible for many of us at this time to go and procure new tanks. So, okay, with that, now, Ved, why don't you address the last question?
Last question is for Dr. Sanjay Shukla. How will you boost patient confidence and counsel patients who choose to undergo treatment in this distressing time?
Yes. So, as I mentioned earlier, counseling is going to play a crucial part more than ever in present day. The information regarding the SARS-CoV-2 and COVID is available on internet, TV, social media, print media, everywhere. And these information have deep impact on the psyche of the patients that are seeking treatment and also on the psyche of the staff. So I would encourage the couple to openly participate in discussion during the counseling session. This has been my favorite part also. I have dealt HIV pandemic also when I started my career. So I enjoy doing this. Try to answer their queries and bust their myths pertaining to COVID-2 pandemic and the possibility of getting their infected during the infertility treatment. They need to understand the safety of the procedures offered to them as treatment and the measures taken by the clinic, doctors, and laboratory staff to avoid any contamination or infection to the couple and their gametes or embryos. The patients should be given enough information about the technical modifications done by the clinics, like the modifications that Sarapreet mentioned regarding their cycle management. The couple also needs to be taught to follow the precautionary measures like the isolation and social distancing all. If they get pregnant, again, what are the precautions that they can take? And the importance of avoiding unnecessary visits to public places, social gatherings, or friends or relatives, etc. So I think if you give enough information, positive information regarding these COVID-19 and coronaviruses, so they must be, you can boost up their morale and they can be prepared for the treatment to follow.
Right. So that's as we can understand that. So counseling becomes very, very important in these times. Thank you, Dr. Sanjay Shukla, and thank you each of the panelists for giving very candid and practical views on all of these questions. We come to the end of the agenda for discussion, the panel discussion. Now I'd quickly like to invite questions. We have the panelists have been very thorough in making comments, and now quickly let's go down to see if we have any questions that I'd like to pose to all our distinguished panelists here. Do we, if the organizers are here, because most of the questions that have been asked have already been addressed. There are a lot of questions on PPE, and we've had adequate discussion and changes in laboratory cleaning. We've had exhaustive discussion on cleaning and precautions. So yes, so we've pretty much now had the entire discussion. So if everybody is fine and they've made their comments, then we can close the discussion here. Ved, thank you very much.
Thank you so much. Thank you for supporting this event. And we can ask Dr. Amol to sum up, close the closing remarks. Huh?
Yeah.
Okay. Thanks once again to all the eminent panelists, and a special thanks to Dr. George, who's been here till, I guess now it's like midnight in Australia, and he's been with us. And a special thanks to Dr. Gaurav and Dr. Ved Prakash for really being a partner in this event and taking us through this. I think this was like a entire journey of the patient within the center, and not only the journey of the patient, but also journey of the gametes within the IVF lab, and discussing the challenges. There were many tricks and, I would say, ticks and trips to dodge. How do you dodge the virus and also follow the processes? All kinds of discussion, right from PPE to disinfectants to embryologists, in-house embryologists, and the various level of protections, ventilation systems. I think nearly all points were covered so well. And I think everybody has been tuned right from the beginning of this webinar. So sincere thanks to all the panelists once again, and again appreciation to Dr. Gaurav and Dr. Ved, and also the entire back-end supporting team from Ferring for taking this ahead. So it's good night to all of you. Stay safe, stay secure.
And about the feedback, there is a feedback that can be filled by all the audience who attended, as well as the panelists. No, not the experts.
Yeah.
And so please go ahead and fill that feedback form. And a special mention for Dr. Pranay, whose presentation was excellent. So we really enjoyed your presentation. And thank you, George, Krishna, Sarapreet, and Ved, and Dr. Shukla for your time. Thank you very much.
Thank you. Thank you.
Thank you very much.
Thank you, everyone. It has been a pleasure.
Thank you. Please
Thank you
fill
for
in
the
the feedback
invitation.
at the bottom of the page. Thank you. Bye-bye.